Next, I'll request Dr. Anurag Badhani to present his perspective also.
Good afternoon, friends and respected seniors. So I'll be talking in favor of anti-VEGF in proliferative DR, and the question remains that can it replace laser? So is this a right question anyway? So no financial interest to disclose. So PRP, as Dr. Subramaniam has already iterated, that it's a gold standard, time tested, many decades, but it does come with a price. And it's practically a destructive procedure and has various side effects like peripheral vision loss, more chances of DME formation in the course of treatment, and loss of contrast sensitivity and night vision. And there are some scenarios in the OPD where we can find that the patient is not able to maintain a sitting posture for long. There are media opacities, a non-dilating pupil. Then doing a good PRP becomes very difficult. And such scenarios are not very uncommon in diabetic clinics. Anti-VEGFs have been revolutionizing our retina practice in the fields of neovascular AMD, DME, ROP, and gradually replacing lasers in some way or the other. And the shift of our aim is to now not just preventing vision loss, but to improving vision quality as well. So this landmark trial is the only trial where both PRP and anti-VEGFs have been compared in high-risk PDRs. And primarily a non-inferiority of the injections have been evaluated for visual acuity outcomes. And as we know, in the ranibizumab group, the injection protocol was to give 4 monthly injections to start with, and then repeat injections if the neovascularization is increasing or worsening. So this is the general outlook in the first 2 years. Eyes with baseline DME required 9 injections median in the first year and another 5 in the second year. But without DME, the eyes required just 7 in the first and 3 in the second year. And largely the protocol S was able to prove that ranibizumab is non-inferior to PRP in terms of visual acuity letter improvement. Also with that, the peripheral visual field loss, need for vitrectomies, and chances of development DME were also far less in the ranibizumab group. And the highlights were that very few eyes in the injection group actually received PRP later during the course of 2 years, and almost half the eyes of PRP group received additional PRP later on. And again, half of the eyes in the PRP group also needed injections for DME, which developed over the course of treatment. Then came the 5-year outcomes in 2018, which again confirmed that the chances of center involving vision affecting DME was far less in ranibizumab group, as well as the chances of surgery, vitrectomy for retinal detachments. But the mean change in visual acuity and visual field loss difference almost approached each other during the course of 5 years. The reason is because we know that injections have a short lasting effect and they do not increase the perfusion of the retina. But it's possible that the peripheral retina finally gets burnt out, which is a good sign, and that is causing the peripheral field loss over the course of time. But still, it is better than the PRP group. These factors usually hold us back from using anti-VEGFs. Number of injections and follow-up visits are more, but it is a much more comfortable procedure for the patients and takes much less time. Cost effectiveness also can improve with time now, as many insurance companies are recognizing anti-VEGF use in diabetic retinopathies. And to prevent endophthalmitis and cataract, if we follow proper protocols, these are almost avoidable. Systemic adverse events are also known that it's practically very safe, and apart from a little caution in those with history of stroke and coronary artery disease. So just a few examples. This eye patient had advanced PDR in both the eyes. The right eye had DME, that's why we gave injections, and with the course of time even the proliferation reduced significantly and never needed PRP over the course of 3 years. And this is the other eye of the patient. We injected anti-VEGF just for a trial, and it showed that the exudation also reduced, and the peripheral the proliferation also significantly reduced with just 1 injection, and it maintained like this for the next 3 years, over the 3 years course. So no time for another case. And the final message is that both PRP and anti-VEGFs are good options. We should customize our approach patient specific, and the main thing which we have to judge in clinic is that whether the patient is capable of following up or not. Anti-VEGF is definitely first line if DME is there with PDR, and it also allows immediate use in eyes with media opacities. PRP continues and will definitely continue to build on a 50-year-old history of saving vision, but anti-VEGF should be used to assist PRP and not aim to replace it. Just decrease the need of PRP in course of time. Thank you.
Can you come to the podium, please? And can you rebut what points he has said in favor of anti-VEGF?
I think finally both of us agree that anti-VEGF cannot replace PRP. It can
Do
be
you
a
agree?
supplement
Do you
to
agree?
PRP.
Our aim is not to replace PRP. PRP is a time-tested procedure. It cannot be.
I think I think
But
he has agreed ki he doesn't wants to do anti-VEGF
See, I
treatment.
was
So
told
you are
that
the winner. The message is clear. The message is clear from Anand also and our opponent who says ki no, I want to do an PRP. And anybody in the audience in favor of anti-VEGF and not doing
Anti-VEGF
pan-retinal?
alone.
Anti-VEGF alone and not doing pan-retinal. Vinay, your opinion?
Yeah.
So, yeah.
Apart from these systemic complications of anti-VEGF, what we are discussing and saying
We
is
can
much more commoner as compared, because more than endophthalmitis I have faced stroke and MI, history of stroke and MI in my injected patients 1 week, 10 days or within a month. Many patients. Fortunately, in our side, the patients are not that much aware, so they never blame us about that injection given in the eye leading to a stroke. But as a doctor, we know that there is some role of our anti-VEGF. So we should be little bit cautious and we should avoid where we can have alternate.
Already
cheaper
the
options.
message, the person who is speaking, Anurag,
He's
who is
already
speaking,
conceded defeat.
conceded defeat. So the message is clear. PRP is the treatment of choice in our scenario.
Yeah.
Western scenario is different,
Different,
but
yeah.
our scenario, PRP.
In
is
our
the-
kind of setting where we don't get patients on a regular follow-up, and then cost is a constraint, people travel distances to take treatment, they may not be able to come back again and again. Injections have their own hazard, monthly injections, and then you are poking a needle into the eye. So I think both have a role in their own self, but not for proliferative disease, and PRP remains effective modality for treatment of PDR in our kind of settings.